The scientific committee, they asked me to speak about this topic is low resource, a barrier to high quality healthcare. I realized that the world is completely different in the way that health is approached, the way it is financed, the way the insurance is covered. And so this has different resonance to different parts of the world, but I would talk about what happens in my country. So 70% have low resource, and this is something that my mentor used to tell us, that however good you are and you have knowledge, but if it is not ultimately to the benefit of whom it's meant to be, the patient, then it's of no worth. Now I'm coming from India, and I am from the city of Coimbatore. And this is very relevant to me because I worked in the UK between 1987 to 91 and went back to India with high aims, but then was found it very challenging because everything was different. Rare presentations which were really rare in UK was the common presentations in India. People came at the end of the natural spectrum of the disease, and they were not only technically challenging and needed the highest quality of care, but many of them were uninsured and self-paying. 60% of the population had an annual income of less than 3,000 per year. Often the patient who was financed was an uncle or a cousin somewhere, and then this was a problem, and government reimbursements were unimaginably low. So in our day-to-day work, there was a bitter truth that everyday surgeons like us had an important job to do, that was to place a price on the health and well-being of a fellow citizen. So when such patients came to you, you either had a choice to say, okay, you can't pay, so I won't do anything, or you took up the challenge and to do something that is relevant to them. And either you give up or challenge the situation, and we took up the second part. I think globally, we have to understand that if we are talking of low resource, it's very important that we use the resource that we have only on interventions which are required. Now, when I say spare the patient of interventions that he needs, it looks too simplistic, but is actually not. Because no longer are we in the older time where there was no stakeholder than the patient and the doctor himself. But now we have the hospital, we have the industry, we have the government, we have the insurance, and we have so many of these. Now the patient's interest is sometimes down. In fact, the doctor's interest also is sometimes down. We have a higher issue of industry, hospital, insurance, and government, and sometimes the patient's interest is somewhere gone. Now, if you look at some of these, you can see that, for example, spine surgery rates are growing up so high. Does it mean that humanity has changed? No. And if you look at different geographical reasons, and the only reason I am putting US is because they have good statistics. We don't have that in India. While the population increased by 23%, spine surgery increased by 137%. And in some states, the rate of spine surgery is 20 times more than others. I'm sure this kind of variation is there in different countries also. In India also, you will find that wherever the spine surgeons are more, then the surgery is so much higher. So it's not the small surgery you're doing or the big surgery you're doing, but if it is not absolutely necessary, it's still the unkindest cut at all. So we should preserve the resource for people who need it. For example, for the disc pathology, we have done everything possible, like burning the disc or electrocoagulating it, magnetotherapy, aspiration, injecting enzymes and stem cells. But if you look at the end, most of these outcomes are not too much better than conservative treatment. So here we have to be sure that we use our resource only for surgeries that are proven, which are simple, which are safe, so that we will be sure that all these increase in the market is for the benefit of the patient. Because cost does matter, because resources ill spent robs others of health resources, and I think that if we just not look at the cutting edge, which is 5 times more costlier than the previous technology, automatically we have a lot of resource left. Second is increase in facility resource can sometimes lead to decrease in efficiency. So we can keep the resources high if we enforce highest form of efficiency inside the operating theaters. So in our center, we also proactively advocate time-tested and proven low-cost therapies and consciously stay away from unproven cutting-edge recent advances. So we all know this COTS parabola, where new ideas come with a high cost, and they are talked about, presented, many instructional course lectures, lunch symposia happen, they stay for 5 years and then go down. But between here and here, they absorb a lot of resources of the health society. And we need to be very careful that we are not falling into the trap of the golden curve of profit of the first 5 years of the industry. Medical industry, we know that if you look at all the new innovations, only 3% have a potential for improvement. Most of them are not. But it is at that period of time, they are very costly. And we have to be sure that whenever we are switching to a higher cost therapy, whether it is really the cost-benefit ratio is worth for the patient. Because many of the new innovations are not sustained, and medical innovations actually prove a lot. Thirdly, we have to increase the power of critical numbers because of the power of cross-subsidy. And we found that because in our unit we do 24,000 orthopedic surgeries every year, that allows us to do 10% of 2,500 highly subsidized surgeries, and we do about 600 free surgeries. For every 10 to 15 surgeries that you do, the unit can absorb 1 free surgery without any major problem. We also use other device techniques like low implant density, local implants, and hybrid technology. For example, this scoliosis, and this is a very low implant density with local implants and hybrid. The entire surgery costs us less than $1,500, but this is the patient after 9 years doing very well. So if you use this technology, you can increase the power of your resource by 5. And we need to actually put this on by putting off many social service projects. And in the last 8 years, we have done more than 4,000 spine surgeries, all for the cost of less than $1,500 per. And that was the reason why we were recognized by this humanitarian award by the SRS. Lastly, we have to be sure that whatever intervention we do, that it is safe. Every complication is resource absorbing. Complications cost 10 times more than normal surgery. And we have to be really careful because in a low resource setting, a patient who could not afford primary surgery cannot afford a revision or a complication. So they steal your resource, you occupied your time, they sap your energy, and you have to be really careful that you invest in technology and also do extremely good audit and review of your performance so that your level of efficiency is very high so that the cost. Here we find that in the unit we have invested a lot on technology and so that we avoid complications. And when you're using these equipments for many hundreds of cases, it does not matter that you use them for free for 1 in 10% of these patients, and they don't eat on your product. Lastly, as our previous speaker said, whenever there is a patient who cannot afford, there is a numerous way of getting over the financial ring if you involve the society. We have involved many charity associations, and we have advertised the power of 5. We tell them if you donate to Red Cross or if you donate to Help or Cry, $100 you donate, only 40 to 50% goes for the actual relief, the other 50 goes in administrative costs. But you give us $100, we will give you the value of $500 of surgery. And that has really caught up in our society, and we have numerous participants for us. Lastly, if you want to cut down costs, then we have to concentrate on prevention. In the old China, a doctor was paid when his patients stayed well. And he was paid every month when the whole family did not have any illness. If somebody fell ill, he didn't get paid that month. So he was really looking after their nutrition, their social behavior, their exercising, and their fitness. And this is what probably societies like AO Spine and everybody has to do. So sickness should make the doctor a pauper. So it should be in the best interest of medical people to have good preventive medicine. And this is what we should do as a whole. As Mahatma Gandhi said, if we are all not a part of the solution, we are also a part of the problem. And I think that by joining hands together, we can make low resource not a barrier for high quality care. Thank you.